Hello, and thank you for joining the podcast Emergency Minute. Your host is an emergency medicine physician who brings over 20 years of experience in healthcare. Dr. Parente will take you through some of the trending topics and challenges faced in the ER and all of healthcare. Join in the fight against misinformation, and don't forget to follow on social media at Dr. J. Parente. Now, here's your host, Dr. John Parente.
All right, welcome back, everyone, to Emergency Minutes. This is episode 14, Interesting Cases in My Career. Do appreciate everyone who has powered through the first 13 episodes. Congratulations on all of your success. You have officially listened to 13 episodes of me completely rambling on about random medical things. All right, so I do appreciate everyone that participates on social media at Dr. J. Parente. Anytime you comment on a post, like it, share it, or send it to someone that you think, hey, maybe this would be interesting or funny. I do appreciate that, and certainly that helps me get this show off the ground, so much love to you. All right, a few weeks ago, we put up a post actually listening to our listeners and saying, hey, what do you guys want for the next podcast? So last week we did medical marijuana, fact or fiction. So I do appreciate everyone that took a listen to that. If you haven't listened to that, check it out. It might surprise you on what I had to say. This week's topic, however, is going to be interesting cases in my career. Next week, we're going to do COVID-19, what really happened, and I'm going to try not to get fired. And then the next one after that, we're going to talk about weight loss and all the myths associated with that, because there are plenty. A little bit of a disclaimer. I have to obviously respect federal privacy laws and HIPAA. So some of the details of these cases are protected, and I need to obviously be somewhat vague. So I will do so and respect federal privacy and not face any giant fines, ideally. All right, let's get into it here with case number one. This is a 30-year-old woman that came in by squad because she was extremely anxious that she could not find her vibrator. Yes, this is an actual real visit to the emergency room. So in my best possible way, I was very professional, and I had to have a conversation with her about this. Ma'am, when did you last see your vibrator? And she said it had been a couple of days. And her biggest concern is that she, number one, didn't know where it was. And number two, she didn't know which hole it was in. Yes, this is an actual conversation. This is not something I made up. So obviously we have to kind of go looking for that kind of thing. So we did examine the, sort of the front door and the back door, so to speak, and really didn't find anything. Now, in the meantime, the husband arrives and has a manual on how this device works and brings it back to the emergency department. And so at this point, I'm interested. You got me. I want to look and see this manual. I want to see how this thing works. So, obviously with a manual, this thing has some battery power to it. So that means there has to be metal. So that means that it would show up on an X-ray. So that was next up on the task list, was to get an X-ray. So we go ahead and we get the X-ray, and sure enough, there's no vibrator. So I go back in to give her the good news, and she could not have been more thrilled and relieved that this was not found. And, at that moment, her heart rate had slowed down. She had some tears of joy, and she's ready to be discharged home. Now, the interesting thing about this, there's a lot of interesting things about this actually, but when she came in, now granted she was anxious, but she was very tachycardic, meaning her heart was like racing. And you have to be careful in emergency medicine, because you can just say, oh, well, I'm sure her heart's racing because she's just anxious and she's tearful, maybe she's in pain, things like that. But the other side of that, in my job in the emergency room, and a lot of people don't realize this, is I always have to think about what's the thing that's going to kill somebody? What's the worst case scenario? Well, worst case scenario in foreign bodies is that there's a perforation. And I've talked about this on other podcasts. I've talked about this in some of my, ridiculous videos that I do on TikTok and Instagram, things like that. But if you have a foreign body in your rectum and that perforates and tears your rectum, that's a big deal. That's a problem. And you can get peritonitis, which is like inflammation, infection in your entire abdomen. This usually leads to obviously a surgery where they have to kind of open you up and repair it. I mean, this is a big deal. So I was relieved. Well, number one, I was relieved that I didn't have to go digging for a vibrator in one of the holes. And number two, I was relieved because I really knew that her heart rate was elevated because of her anxiousness and anxiety around the lost vibrator. And after I had told her that, hey, look, there's no signs of the vibrator or anything else, her heart rate came back down to a safer level. And I'm like, okay, there's nothing more dangerous going on here. So definitely an interesting case, one that I will never forget. Now, I am not a woman and I have never shoved anything in my body, but I'd like to think that if I did, I would know it was there and not lose track of it. But I digress. All right, let's go on to the next case. This is probably one of my most memorable cases I've ever had in my entire 18-year career. And this was from a long time ago, back in my residency, but this one I will never forget. So this is a story of a late 20s male who was at home with his fiance on New Year's Eve when something happened, an argument between the two of them. And in a reasonable fashion, when men and women get into arguments, the next logical thing that happens is that the woman would stab him 7 times and then tearfully call EMS because she had just stabbed her fiance 7 times. Totally reasonable, right? It's like Tuesday night at my house. So this male comes to our emergency department, obviously in a world of hurt, on New Year's Eve. Now, to set the stage here for you, this is a pretty big trauma center, and this place is absolutely on fire on New Year's Eve. I'm talking every bed in the ER full, the entire waiting room full, 40 different people in hall beds. And if you know anything about hall beds, that means you're in a hallway on a chair, on a cart, anything that we can put you on to at least have you evaluated by a physician or a physician assistant. And this place was absolutely burning down. And that's just makes the story even that much more interesting. So this patient comes in by squad, multiple stab wounds to the chest and the abdomen. And as we're evaluating him very quickly in the trauma bay, he starts to decompensate. And by that, I mean the heart rate starts to go, then the blood pressure drops, and then all of a sudden he becomes what's called a trauma arrest. And if you know anything about trauma arrest, the mortality, meaning the chances of death, are extraordinarily high. So we were doing things in the meantime to try to prevent this, of course, establishing an IV. Once you realize that there's a chest full of blood, we're putting in chest tubes, and she had stabbed him on both sides. So we had chest tubes on both sides, one on each side, draining blood, reinflating his lungs. So we're going through this. And then obviously, once you go into cardiac arrest from penetrating trauma, meaning stab wounds or shot, anything that penetrates into your chest, you have to crack open the chest because obviously, there's a lot of things that you need to look for, but one of the things that we look for is blood that's around the heart that's constricting the heart and not allowing it to work appropriately. So that's one of the reasons why we do that. So in this particular case, we ended up having to open up the chest. And when we opened the chest, we did find that the pericardium, which is the sac around the heart, was completely full of blood. So at this point, the process now is to cut the pericardium in order to evacuate the blood and allow the heart to then resume pumping, hopefully. And so we did that. We cut the pericardium, and imagine if there was like a little man standing inside of the chest of this patient that had a bucket full of blood, and then the moment you cut the pericardium, he just tossed this bucket of blood onto you and to the floor. And that's exactly what it looked like. It looked like it just came flying out of there. That's how much pressure was on the pericardium, and that's how much blood can accumulate in that space in a very short period of time when you are stabbed by your loved ones. So that was very interesting. And at that moment, obviously, we have a clamshell. It's called a clamshell, meaning the left and right chest are completely open like the hood of a car. Now, the senior surgical resident at this point is on top of this patient, straddling this patient, and using his hands to, number one, make the heart contract because it did not restart. Also, number two, to kind of see if we can look, examine, feel where is the laceration? Where is the stab wound? Is it in the heart? Is it in the pulmonary arteries and veins? Is it in the aorta? Because those are kind of the three main areas where you can die very quickly. Now, in the meantime, this patient's been intubated, meaning they're on life support from a respiratory standpoint. That was pretty much my job. Already had the chest tubes, which at this point are worthless because we have the chest filleted open. And then, of course, has trauma lines where we're infusing blood. Now, at this point, we have the only chance of survival here, which, by the way, is less than 1% with a trauma arrest in this situation where you open up the chest, is to get this patient to the operating room to determine where are the lacerations, can we repair them, and then can we get the heart restarted, or has patient lost too much blood, etc. So that's sort of where we're going. So in the meantime, we're in the trauma bay. Now, we have to get to the OR, and at this particular facility, this is on a different floor. So we actually had to take an elevator. And again, like we talked about before, this was New Year's Eve and the place was on fire. There were people everywhere. So we're leaving the trauma bay with the surgical resident straddling this patient, squeezing the heart with the chest filleted open. This is not something that you can really hide. And I'll never forget the looks of the faces of the patients in the hallway as we're wheeling by as quickly as we can and safely as we can with this person's chest filleted open as we're doing basically manual contractions of the patient's heart. That's something I don't think I will ever forget. And, it's interesting because we get a lot of people that come to the ER for really strange reasons and things that are not anywhere near an emergency. And sometimes I think that gives a little bit of perspective when we're doing manual compressions on somebody's heart. But nonetheless, I digress. So we're going out into the hallway. Now, keep in mind, we're giving this patient trauma blood. And for those of you guys out there that do donate blood, shout out to you. Don't forget to donate blood at your next blood drive, because this is the type of thing that saves people's lives. In a situation like this was honestly his only chance. So we're giving the blood through pressure bags. So we're trying to infuse this blood as quickly as possible because he really had no blood pressure. He was essentially bleeding to death. So we're flying around the corner and one of the blood tubings actually gets caught on something on the door. Well, imagine if you had a pressurized bag full of blood under that pressure and you cut the tubing. It's like a fire hose under pressure full of blood. And so it was like something out of a bad horror movie, like a B flick, where there's just blood being hosed all over this hallway. And, at the time, you really couldn't do anything but try to get control of it and then chuckle to yourself. And we were able to get it under control and we made it into the elevator. Now, keep in mind, it's New Year's Eve. I'm sweating. We're on this elevator with like 7 people, 7 physicians. And all you hear is as the surgical resident is manually pumping this patient's heart. And I looked down at my watch, and at that moment, it hit midnight, and it was New Year's Eve. We got off the elevator because it was like, ding. And I'm like, well, Happy New Year's, everyone. So ultimately, the patient ended up going to the operating room. They did find lacerations that they tried to repair in the heart. They found lacerations also in the pulmonary arteries. But at the end of the day, this patient would succumb to his injuries, and he did pass away. So I'm walking back down to the emergency department because one of the craziest things about emergency medicine is you deal with something so catastrophic like this, and then you come back to a completely full department and you have 8 more hours left in your shift. It's one of the most wildest things that we deal with is dealing with that type of trauma. You don't even have 2 seconds to think about what just happened. So I'm coming back down to the ER and I walk through that hallway and it was like a scene out of Carrie, the movie Carrie, the horror movie. And there was just blood everywhere. It was awful. And so I remember going up to the secretary and I'm like, could we get housekeeping to the hallway? Because we're going to need cleanup on aisle 3. And so that's what happened. And I don't think I'll ever forget that night in my entire life. I think the moral of the story here is be careful who you ask to marry. I think that's what I took away from that. All right, case number 3 is going to be roughly 30-year-old female that was brought in by a state trooper driving erratically on the road. And they pulled her over, realized that she was altered, and brought her in for medical evaluation. Now, when people come in altered, it's one of the most difficult things that we have to deal with in the emergency room because we can't really get any history. We don't know what the heck happened. Sometimes patients aren't able to tell us, do they have any medical history? Are they on any medications? especially when they're from out of town, out of state. It is extremely difficult. And medicine's very far behind when it comes to like sharing information amongst other hospitals or cities. Many years ago, HIPAA was created, and the idea that we had to protect patient privacy is a good idea. The problem is HIPAA took it so far that it made it very difficult, and it set us back in other areas such as sharing information. And what people don't realize is that information is critical for us to be able to treat patients appropriately, quickly, and also cost effectively. There's one estimate I read once was that there's $8 billion per year that's spent in healthcare on repeating tests just because someone can't find the test, can't get the test. Like, so for example, if a patient was at, a different healthcare facility today, they had blood work done, and then they come to my facility and they have belly pain or whatever it may be, like I probably have to repeat that because I'm not going to be able to see the blood work from over there. Now, we've gotten better in Ohio. There's been some ability for us to be able to see other things. So it's getting better, but it is very much annoying when we can't see any of this stuff. But nonetheless, back to the case. This 30-year-old woman, she really couldn't tell me anything. She was definitely altered. She was definitely under the influence of something. And that's obviously why the state troopers had brought her in. She wasn't from there, but she really wasn't being honest and forthcoming about where she comes from. Now, in the meantime, I don't know if she's not telling me because she doesn't want me to know and she thinks I'm the police or something along those lines. Or does she have something seriously wrong with her and she cannot tell me? So there's a big difference between not being willing to share information and not being able to. And again, going back to what I said before, I have to think of the worst case scenario in all of these ER visits. Worst case scenario, she has a brain bleed, she has a brain tumor, she has meningitis, she has sepsis and can't think clearly, she is in renal failure and her BUN is so high that she's completely altered, or is she drunk, or is she on drugs? So you have to look at all these different things. You can't just be like, she's just high because she's on drugs. So we're going through this workup. So a workup for somebody like this in this situation that's altered and you don't really know why is very broad, right? So we have to cast a wide net to look at all different things. So we're doing EKG for heart. We're doing blood work, look for infection, for anemia, for dehydration, kidney failure, electrolytes. Of course, we're going to check drug screen. Of course, we're going to check alcohol. We're going to do a chest x-ray to look for any sort of pathology in the chest, pneumonia or anything like that. And then, yes, we're going to do a CT of the brain to make sure, no brain tumors, brain bleeds, things like that. So we're getting all these tests ordered and basically everything is kind of coming back negative one by one. CT brain's negative, chest x-ray, EKG, but she's still kind of altered. And I'm just like, something's not right here. And so then it turns out that police are able to determine, and they share this information with me, that she was actually in a different hospital earlier that day for some other unknown medical issue. And then she was treated and released and was driving from that hospital to our hospital, had been in some type of a car wreck because there was some damage to the car, and then started driving erratically on the road. So it's kind of bizarre. So now you're like, well, is this trauma? Did this person get, hit in the head? Was this a head injury that now she's altered? I think that would be unlikely with a negative CT of the brain because you'd expect to see like blood in the brain or something along those lines, but it's certainly not impossible. So almost all the tests are back. And I'm like, what is going on with this woman? The alcohol level's 0. And, so we're trying. And so I look and I'm like, wait a minute, I don't have the urine drugs of abuse. And so I talked to the nurse. I'm like, hey, listen, we got to get urine from her because we need to find out. I mean, if she's, lights up 5 different drugs on her urine, then we could say, okay, she's altered because she was doing drugs. And the nurses are like, yeah, she hasn't been able to pee for us. I'm like, well, you've got to go get this. I mean, this has been hours now and we have every other test in the world back. And this changes things. Like if it's just drugs, okay, fine. Like we can deal with that. But if the urine test comes back negative, well, we got to look deeper. Do we need to do a lumbar puncture? Does she need an MRI of her brain? Like this is going to be, she's going to need to be admitted to the hospital and this is going to be a much bigger deal. So they're asking this patient, and now at this point, she's kind of coming around a little bit. She's like following commands, like she's somewhat cooperative with us. So we're asking her for this urine. We're asking. And ultimately, she's just like, I'm not going to pee for you. And at this point, I'm realizing that now that she's kind of refusing, it's not that she's not able to give us the urine. Now it seems that she's more like not willing to give us the urine. So ultimately, I'm like, look, she's still altered. Like, we have to figure this out. So we have to go in there and cath her to get a urine so that we can make sure that she doesn't have a urine infection and make sure that she has, get her urine drugs of abuse. So as we're about to go and put a catheter in this woman just to get the urine quickly, lo and behold, the nurses discover that inside of her vagina is a giant canister of narcotics. So they bring it over to me and I'm like, well, what the hell? That's interesting. That explains a lot. So we were able to identify the narcotics using some online pill sort of identifiers. And we were able to get the urine drugs of abuse test, which lit up like a Christmas tree. And at this point now, workup kind of changes because now, she could be a mule. She could be, packing things in her body. So now I got to look at some imaging of her abdomen to see if there's anything else shoved anywhere else on her body. And it turns out that there was not, thankfully. So I didn't have to go chasing anything else other than this giant canister of narcotics, which was shoved in her vagina. So it turns out that this patient was actually traveling across state lines and she was transporting narcotics from one location to another across different states. And Ohio just happened to be along the way. And the patient was sampling some of the products as she was making her triumphant journey across the state lines. So we ended up admitting her to the hospital. And my understanding is she became more alert and more cognizant of what was going on and things like that over, the next several hours. And at that point, she picked up her stuff and went running out the front door of the hospital and left. And it just always boggled my mind because, here's this person who's driving erratically, had already been in one accident, was clearly under the influence, and wasn't under arrest or anything else. And it always blew my mind that person could just walk out the front door of the hospital. And I always talk about, you guys heard me talk about this at length about how healthcare is broken. Well, apparently, the police system is also broken because that always blew my mind. I don't know where the hell her car was, but it wasn't at the hospital. I'm not really ever sure what happened to her because she went running out the front door, and we did call PD to say, hey, this person left, but she's allowed to leave. We can't hold her against her will. At this point, she was alert, she was oriented, she's able to walk, talk, etc. So I don't know where she went. I don't know whatever happened to her, but I don't think that's a case that I will ever forget. All right, next case number 4. This is a case that I will also never forget. So I'm at a very busy emergency department. This was a few years ago, and the place is burning down. Common theme here, obviously, in my discussion of all these cases. And so I've got a very, very long patient workload. So I have numerous active patients. And, when the more patients you put on an ER physician, like I just get more anxious because I don't want to miss anything. And obviously, if you're a juggler and you're juggling 2 balls, that's a lot easier than if you're juggling, 15 balls. And it's the same thing with healthcare, only these are people's lives. They're not balls that can fall to the ground. So, the adage in emergency medicine is that if you're juggling 1,000 balls, there are going to be balls that hit the ground. You just hope the balls that are hitting the ground aren't anything important. In this day and age with limited staffing and the demand to do more and more and more with less and less and less, it's inevitable that mistakes are going to happen, unfortunately. So you just hope the mistakes are simple ones like, oh, I put this order in on the wrong patient and I can identify that quickly and cancel the order and put it on the right patient. Things like that happen every day that would probably terrify the general public if they saw this kind of stuff. But that's why you're listening to this podcast, because like I said, I keep it real and we'll give you the inside scoop to medicine. Meanwhile, back at the ranch. So we're at this very busy emergency department. I'm already at my absolute capacity. Like, I don't know that I could take a single other patient because I am juggling so much right now and so many sick patients. I'm done. I'm like, oh my gosh, this is out of control. And I remember a nurse that I have nothing but respect for, phenomenal nurse, comes up to me, kind of grabs me, is like, listen, you gotta see this lady real quick. And I'm like, I don't know that I can. Can you ask one of the other docs? Like, I am drowning. And she's like, no, this will be really easy. She's just a psych patient who's here with suicidal ideation. She's, I forget, she's like 65 years old and she wants to kill herself. So all I need you to do is just like walk into the room, say, introduce yourself. Hey, I hear you're having some thoughts of suicide. And then we can get her out of here over to the psych unit and, continue the medical workup, make sure medically everything's okay. But in the meantime, you really just have to kind of go in there and say hello, because the way psych patients work in the ER is that my job primarily is just to make sure there's nothing medically going on acutely. And then once we say, okay, the patient's medically clear, then they can be addressed by the psychiatrist, whether that be a counselor or, every community and every hospital has a little different system. But the point is it works the same just about everywhere. Medically, you have to make sure things are okay first. So I'm, in there and I'm like, hi, I'm Dr. Parente. I'm just here for the medical stuff. I understand that you wanted to harm yourself and so, are you having pain anywhere, pain in your head, pain in your chest, pain in your abdomen, just trying to talk as fast as I can because I got to get out of this room because I have patients who are literally dying and strokes and traumas and sepsis, and it's insane. So she's like, well, yeah, I do have some chest pain. And I'm like, oh, for the love of God. And, anytime someone says the word chest pain in the emergency department, that pretty much buys them an EKG, a chest x-ray, and, labs, because we can't miss, the dangerous things. Pneumonia, heart attack, blood clots like PE. These are things that we can't miss. And no matter what, if you come into the ER every single day and you're like, I have chest pain, we're still going to have to do that workup because the whole cry wolf thing, right? Eventually you may actually have something wrong with you. So she tells me that she has chest pain. So now I'm stuck in this room and now I'm like, okay, when did the chest pain begin? Oh, it was yesterday. Okay. Were you doing anything at the time? Now, the reason why we ask that is because if this is cardiac chest pain, meaning the pain is being caused from your heart, an angina, usually it's exertional, meaning, yeah, when I ran up a flight of stairs, I had chest pain. Well, that kind of points more towards your heart. Well, not this woman. No. I said, what were you doing at the time? And she said, I stabbed myself. And I'm like, wait a minute, hold on. You're telling me that you stabbed yourself in the chest yesterday? And she's like, yeah. Now, keep in mind, she's here for a psychiatric emergency medicine visit. And one thing you realize about psych patients with mental health disease is that they lie. And not always, but they do lie. And you have to I always tell my residents and my students, when a patient tells you, especially a psychiatric patient, that they took something or they did something, you kind of have to believe them because you got to pursue that. So I always say, believe everything and believe nothing. So for example, if somebody said to me, hey, I took an entire bottle of Tylenol, well, maybe they did take an entire bottle of Tylenol and I need to pursue that. But maybe they lied or maybe they were wrong and maybe it was aspirin, which is a completely different treatment. So you have to believe what they say and then believe nothing. So for this lady, I did both and I'm like, okay, so you stabbed yourself in the chest yesterday. She's like, yeah. So I'm like, okay. So I go and look and just beneath her left breast, which is right where your heart is, sure as shit, there's a large laceration underneath there that looks like a stab wound. That has completely, looks like it's healed up from yesterday, but it does look like it was a fresh cut. Now, if you've ever, a lot of you probably have not ever seen a stab wound. Stab wounds are very anticlimactic. You'd think it's going to be like this gory, big, nasty thing. Well, no, it's just like a little cut. It's the size of the knife, especially if the knife wasn't that big. So they often look very underwhelming, but I'm like, it does look like she stabbed herself. So of course I go grab the nurse and I'm just like, you got to be kidding me. I'm like, you pull me into this room for a quick, easy psych patient that we could just medically clear and then go send to psych. This woman stabbed herself in the chest. She's like a trauma patient now. By some miracle, she had completely normal labs. So I go through this workup in the meantime, juggling 700 other patients, and ended up doing a CT of her chest. First, I did an X-ray because we want to make sure she doesn't have a collapsed lung, which she did not. So then, which is a miracle, by the way. So then we do a CT of her chest, and one of the most impressive CTs I've ever seen in my career because she has this giant cutout in her lung where you can see the stab wound from the day before. And sure as shit, this lady literally samurai'd herself in the left chest and lived to tell about it the next day. So I'll never forget the phone call I made to the CT surgeon, the chest surgeon. And I'm like, you're never going to believe this. I was like, but I'm calling you because this woman samurai'd herself in the left chest yesterday and then came in today with completely normal vital signs because she wanted to get help because she was having obviously suicidal ideation. And I told him this story and I just remember him just kind of laughing. He's like, that's insane. He's like, I don't know that I've ever seen that. So we ended up obviously putting her into the hospital to have her see CT surgery and determine if there was anything to do. And at the end of the day, we really didn't do anything because she had already sealed up the wound. She didn't have a pneumothorax, which is a collapsed lung. She didn't have a hemothorax where there's like blood in the lung. She pretty much healed right away. She missed the heart by some miracle. It's absolutely fascinating to me, this case. And the other part that's crazy about it is that she actually got the mental help that she came to the ER for eventually after we medically made sure everything was okay. And then she actually tried this again. I wasn't there, but this is just from when I was talking to some of the staff. She actually tried this again like a month or two later. So it's crazy. Very crazy case that I don't think I'll ever forget. So remember to talk to your loved ones. Suicide, obviously a very serious thing. And clearly this patient was very serious about trying to take her life. So remember, the suicide hotline is 988. There's always help available, someone to talk to. So please don't hesitate to reach out to your loved ones, check in on them. 988 is the number if anyone's having any thoughts of self-harm. All right, next up and final case here is case number 5. This is a case of a 20-year-old female that came in by squad because she was unresponsive. She had been at work earlier in the day, and it was her first day on the job. So she came in to work and was seemingly okay, and then she was found, back in the storage room on the ground, unresponsive, and brought in to see us. So like I talked about before, this presents a lot of unique challenges because this person was found on the floor unresponsive, and, just prior to that had been seen walking, talking, and doing just fine. So again, differential diagnosis, like what could be going on here? Very, very broad. Could she have had an intracranial hemorrhage, meaning bleeding in the brain that dropped her to the ground? Absolutely. A ruptured aneurysm, something like that would definitely put her to the ground. We do see this from time to time. Could she have had something cardiac, a blood clot, like a PE? Could she have had a dysrhythmia on her heart? Could she have had a heart attack? Oh, unlikely. She's in her 20s, but certainly not impossible. Those are all things that we need to check for. Toxicology, maybe, but she was just seen, completely normal previous to this episode. So obviously, very big workup. We're doing a CT scan of the brain. That comes back negative. Chest x-ray, negative. All of her labs coming back, CBC, CMP, all her electrolytes, kidney function, liver function, all these things coming back negative. We have no answers as to what's causing this. And at this point, she was completely unresponsive, meaning that her GCS was 3. So the Glasgow Coma Scale is a way for us to determine how awake, how alert, how responsive is somebody. And it goes all the way up to 15. And like a piece of furniture has a 3. So 3 is obviously really, really, really low, like dead person or a piece of furniture. 15 is someone who's walking and talking and appropriate. So we look at that, and it's based on eye opening, your verbal response, and then also movements and motor function. So we do this scale. So anybody that's less than 8 needs to be intubated for the most part. So this person was literally a 3. She was completely unresponsive. So she needed to be intubated. So she had a tube down her throat. She's on, essentially what people consider life support to the lay public. And we're doing all these things, and we're coming up completely empty. And so I look at the lab tests and I'm like, okay, what test are we missing here? And I'm like, oh wait, the alcohol's not back yet. Why is the alcohol not back? And I'm like, well, that doesn't make any sense. They just saw her. She checked into work and she was doing just fine. It can't possibly be alcohol. Well, then the lab calls a little while later and the alcohol level was over 500. So that's a really high number. Legal limit is 80. So, obviously anything over 80 is considered intoxicated. And this person's was like 500. Now, keep in mind, people have died with alcohols in the 300s, 400s, etc. You can get, alcoholic encephalopathy. Plenty of famous people have died from that before. So this is a very serious thing. But the interesting thing is how on earth did someone who is completely alert, oriented, walking, talking, checking into work, and then within an hour is on the floor unresponsive because of an alcohol level that's one of the highest I've ever seen in my career? Yeah, so she did butt chugging, and she butt chugged an entire bottle of vodka. Insane. And that's what caused, obviously, very hyper absorption of the vodka, and the alcohol levels were so high that it, obviously had her completely unresponsive to the point where she was on a ventilator. So you could probably imagine her surprise. She showed up to work, shoved a bottle of vodka up her ass, became unresponsive, ended up on a ventilator in the ICU. That doesn't sound like a good way to wake up to me. That would be one hell of a story to tell your family and friends. So I'm not really sure what the infatuation is with shoving things up your ass. Not really my speed, although, don't knock it till you try it, but I don't think I'm interested in trying it. But that's something that we do see in the emergency department and always offers us just a little bit of entertainment. Luckily, she did well otherwise and just probably has some crazy stories to tell the grandkids someday. All right, so that's all I have for the show today. Let me know your thoughts on this format because I do have about 5 or 10 other cases that I want to discuss, but I didn't want to make this episode super long. And we could talk more about that. Like I said, join us next time. We're going to talk about COVID and the real story, what happened at the hospitals and what went right, what went wrong, how everything was so different amongst the different hospitals. So you're going to definitely want to check that out. And as always, I appreciate you all for listening. Please comment, share, send this to someone that you think might like it. And I do appreciate any reviews. I'm on every major platform for podcasts, Spotify, Google, and of course, Apple. So I do appreciate any reviews, any feedback, good or bad. Nonetheless, would love to hear from y'all. So I hope you guys have a great week. We're coming up on another disappointing Brown season that's about to bestow us. So that's exciting. And don't forget to reach out to your loved ones and check in on them, make sure they're doing okay. And as always, peace, love, and happiness to everyone out there. Cheers, everyone.
Thanks for joining us this week on Emergency Minute. Join us next time for more hard-hitting discussions on some of today's issues in healthcare. Don't forget to leave us a review on Spotify or follow on social media at Dr. J. Parente.